Hello, ladies and gentlemen. It is truly a pleasure and a privilege to be speaking with you today. My name is Balicer. I'm the Chief Innovation Officer for Clalit, Israel's largest healthcare organization, and I also serve as chairman of the National Experts Advisory Panel on COVID-19 response here in Israel. And what we will be discussing today is how one can use data, digital data, and innovation in general in order to improve response to the COVID-19 ongoing global crisis, as well as to assess vaccine effectiveness. Now, COVID-19 in Israel has followed until now three main waves of infection. First one back in March, April, second one on August, September of 2020, and the latest one that has begun on December and has still actually is continuing until this very day in Israel, as you can see here. Now, in each wave, we had a whole wave of innovation that we have tried to introduce in order to better tackle the challenges at hand. And I will give just a very brief few examples before diving into the vaccination campaign. So in the first wave, what we have done is that we've used the Clalit data set. Now, Clalit, as I said, is the largest healthcare payer provider system in Israel. It's responsible for the care of over 50% of the Israeli population, over 4.7 million people, and it provides care to the entire population all around the country, inpatient, outpatient, and has full digital data on all aspects. Now, the data is really huge. It is really fully representative of the entire country's population, north to south. It has primary, specialty, hospital care, provider view, and payer view. And because of the fact we have only one basic EMR system, one in the community and one for the hospital system, there's no coding and data entry harmonization issues. So all of this data that is available to us allows us to do really intricate operations with this data in order to improve patient care, all with a very close cyber and privacy maintenance scheme. Now, at the first wave, what we've done was to use this data in order to create a predictive model of which patients are going to be hospitalized and later on identified with a severe illness. And this very advanced predictive model allowed us basically to tell those patients to stay home and to prevent themselves from infection. And that's how we were able to reduce some of the morbidity among those high-risk populations. And actually, what we saw in this graph, you see a comparison of many countries in their case fatality rates, the percentage of people that get the infection and that actually follow up to have a severe disease and die. And you can see various countries in here along the axis of time. And what we see here is that of Israel, which has maintained, I think, until now, the lowest case fatality rates, even in the worst waves that we've had. The second wave that we've seen back in September, the key problem was testing, and we didn't know exactly how to best allocate our tests. And what we've done, we created the whole ability to do a lot of testing. You can see here, again, a comparison by our world in data of many countries' testing capacity. And you can see that Israel has really tried to maintain a very high level of performance of tests, but still that was not enough to contain this huge wave of infections that we've seen. And so what we've done is we created a predictive model that told us which patients are going to have an illness, get infected, and which are not. And we could predict the future for our clinics and for our districts and hospitals and tell them when a patient comes into the clinic that he is at high risk of being infected. And so they can allocate the tests and ask the questions about symptoms at that point. The third wave, which is what we are still currently experiencing, has been manifested with the introduction of new variants in the country. And so the Kent UK strain B117 has now become the dominating strain here in Israel. And it is now over 90% of the new cases in the country. And this change has happened really between late December and today. It has moved from 10% to over 90% of the new cases. Now, in terms of the South African strain, as it's called, it's also, we do know that it does have a presence here in Israel, but fairly small number. And we think that only a few dozens to few hundred cases have happened in the country thus so far. So this is kind of an overview of how we utilize our data resources in various practical purposes and innovative ways in order to tackle some of the challenges that we have. Now, this brings us to our vaccination campaign. And indeed, Israel has been one of the earliest countries to begin a vaccination campaign after the UK. And we've been ongoingly vaccinating people since December 19, 2020, I'm sorry. In this time period, we have provided to date 7.5 million doses of vaccines, and we have been able to vaccinate 4.4 million individuals in a country of less than 9 million people. Now, of these, we have followed protocol per the Pfizer-BioNTech recommendation and what the clinical trials have shown. And we have provided all of our patients with their second dose at 21 days after the first dose. And by now, 2.5 million individuals have already been receiving the 2 doses and have elapsed more than 1 week after the second dose, which means they are fully protected at this point, which means that almost between 1/4 and 1/3 of the country is already fully protected through the vaccination campaign. Now, indeed, in international comparison, the fact that we've been able to cover 49% of our population, and the fact that, you know, a good proportion of our population is young kids that cannot be vaccinated at this point, this is a really speedy vaccination campaign in global comparisons, and it begs the questions of how did that come to happen? How were we able to vaccinate so many people in such a short amount of time? And so there are several, I think, attributes that allowed us to make this thing possible, and we will touch upon them slightly. First of all, I don't think it is completely fair to compare a vaccination campaign in Israel and in other countries because of the great difference in 2 things. One is the sheer size. The entire country is only 9 million people, which is a very small dent in the international production lines of vaccines. And it is very different when you take a large European or a country like the US with hundreds of millions of people that need to get vaccinated and compare them to a country of 9 million people. The second point is that Israel is younger. So our older population was easier or smaller to cover. And because the country is geographically condensed, it is easier to do the logistics associated from moving the vaccines from the airports to the freezers and from the freezers to the vaccination clinics in a very straightforward manner, which was helpful. But I will mention some of the unique attributes that allowed our campaign to be successful. The second point that you see here in the list is the distribution chain. And indeed, we had a very clear distribution chain where the Ministry of Health was responsible for care of the vaccines from the planes that have brought the vaccines in to the storage centers with the big freezers that are required to maintain the Pfizer-BioNTech vaccines in the right temperature, which was at the beginning a great challenge. And from that point and back to the vaccination clinics, that's where the HMOs came to play. So Clalit is one, as I said before, Clalit is one of the 4 health maintenance organizations that are responsible for the care of every Israeli citizen from cradle to grave. And it is the fact that because there's universal coverage and everybody knows their family physician and there's a direct contact, it allows those organizations, the HMOs, the health organizations, to fairly quickly open vaccination clinics and to be able to contact the patients directly and bring them in. And that was exceedingly important in this. Now, these health organizations are basically used to doing community care, outreach-focused efforts, be it annual vaccination campaigns for influenza and others, and also outreach for many other types of preventive health care services. This is something that we used to, so that was very helpful in this campaign. The fact that the health system in Israel is completely digitized for over 20 years was also helpful. As I showed before, there's a lot of data in the data warehouse and in the data repositories, but it's not only that, it's that, you know, all of the connection with these sick funds or the HMOs is done through apps, and each patient has their app on their phones, and they can very quickly, we made it available for them to make an appointment at the vaccination clinic. And when you come in, you only swipe your card and immediately all your data comes in. They don't need to ask you questions, and they already do a formal appointment for the second vaccine in the due time in the right place. So that's helpful. So the scheduling was very key for those older populations that were not, don't have good access to digital health. We had call centers that called them and brought them in proactively in order to make sure that they come in and get vaccinated. We started with very simple indication category: everyone above the age of 60 or healthcare professional. That made it very simple for the public to know when they are due to come in. And later on, we moved to 50 years and older, 40 years and older, and now everybody above the age of 16 is invited to come in. And indeed, as we see, 50% of the population already received their vaccines, over 2/3 of those that are eligible. Finally, the issue of vaccine hesitancy is always an issue. In order to tackle that, what we have done is, first of all, we were exceedingly transparent in explaining facts as facts and unknowns. When we didn't know, we said we do not know. And we had a lot of two things that I'll mention very briefly. One is operational agility, which is whenever we came close to the end of the vaccination day, and the opened vials might be destroyed if they're not used in due time, we ignored the indications, and everybody that were in the neighborhood were invited to come in and enjoy the extra doses, so nothing will be destroyed. And less than 0.1% of the vaccines were actually destroyed. Finally, we went to the communities, to the community leaders. We had discussions, open discussions with them, very open. I myself went, for instance, for a rabbinical class with some leaders of the ultra-Orthodox Jewish community, and they grilled me for 2.5 hours on the evidence and the safety issues. And after 2.5 hours, the chief rabbis there said, okay, I'm convinced this is appropriate, and had later on issued a rabbinical verdict that says it's important to get vaccinated. So this is how you motivate people of different communities to come in and get vaccinated. And now we see that all of those sub-communities are catching up in terms of the vaccination campaign. Same to go in different languages: Arab-speaking, Hebrew-speaking, Russian-speaking ads and leaders working with all communities. Let's talk a little bit about vaccine effectiveness. Because of the richness of data that we had, there was an opportunity for us to study in real time what the vaccine effectiveness might be. But there are potential pitfalls we have to remember. When you want to do such a study, you are trying to emulate the clinical trial, like the one that was published at the New England Journal of Medicine by Pollack and et al., that has been used at clinical randomized setting trial to assess vaccine effectiveness. Now, to do this in real world data is difficult because the vaccinees, those that are vaccinated and those that are not vaccinated, are different. First of all, they're different at baseline because they are different demographic. Geographic is different. In some geographies, they vaccinate less. They're different in their health status, in their health-seeking behavior. And so the likelihood of an infection and of illness, severe illness and death, is different in baseline between those two populations, and you need to carefully make them comparable. Now, the characteristics of those vaccinated also change over time, which adds another level of complexity to this issue. And because of this change over time, you really need to make sure that you compare apples to apples at the same time. And finally, the infection rates in the country also change over time, and they change differentially. In some places, they change in one pace, and in another area, they change in a differential way. So these are some of the pitfalls of trying to do a proper vaccine effectiveness study in a real world setting. Now, just to give you an example of how this actually works, you can see here how infections change differentially over time. So you can see two subgroups here, those at the age over 60 and those at the age below the age of 60. And you can see this here in this Our World in Data graph, how different these different groups had seen different trends in infection over time in Israel during the vaccination campaign. The vaccine uptake is differential demographically. So those that are vaccinated, and it is now difficult to find unvaccinated individuals at the age of 70 to 79. So you must take into account that whenever you have a couplet of a vaccinated and unvaccinated, the unvaccinated might as well get vaccinated soon, and you need to understand what you do at that event in your study. Vaccinated demographics change over time, and you can see here how those who got vaccinated above and beyond the age of 60 are different. So in this time period, it was almost only above the age of 60 that get vaccinated. And when you talk about the age group of 60 to 59, you can see how they slowly gain traction over time. So this is also a challenge. In terms of locality, what we show in this graph, and I will be very quick about it, is that in brief, in Israel, the localities that had the lowest socioeconomical status had the highest rates of infection and the lowest rates of vaccination. So vaccination was inversely associated with the potential a priori of infection. If you don't put the geography and the demography into your account, you will lose, you will not be able to do this properly. What we see here is that on February 6th, we had a situation where 72% of our above 60 population was already vaccinated and protected with 2 doses. And at that time, what we can see is that a gap was already building between the over age of 60 that were going down and the younger age groups that where the infection was continuing as usual. Now, how do you tackle such methodological challenges? Well, I will be brief, but you have to aim to emulate a target trial. And beyond the IRB aspects, you should probably do a retrospective cohort approach, comparing vaccinated and unvaccinated individuals. We do believe that a test negative design can only overcome very few of the challenges we've shown before. So the restricted approach of only those that were tested might be used as sensitivity analysis, but not as your main analysis. And you have to match. And you have to really carefully match. And you should probably match on many different things of age and geography and demography and previous healthcare consumption patterns and health-seeking behavior. And if you don't do that, you will not be able to control the confounders. Now, how do you know you've done it right? There's a test. If you take a look at ages 5 to 12 in your group, if you've done it right, they should have the same rate of whatever outcome you're looking for: infection, hospitalization, severe morbidity. They should look very similarly in days 5 to 12 after the vaccine. And if they do, then you know you're fine. You've been able to pull it through. Now, so in the preliminary data that we've published, or not published, that we've released 10 days ago, we have shown that we've done all of that. And we said that we found some solutions to all of this by adjusting for geography, by emulating and recruiting and matching cases and controls, and by exploring issues such as informative censoring. And to cut a long story short, what we found was that the Pfizer-BioNTech vaccine provided in Israel has shown a vaccine effectiveness of 94% in preventing symptomatic infections and 92% vaccine effectiveness in preventing severe illness. And we were very surprised, happily surprised to see these results, because they are very similar to what was seen in the clinical trial that Pfizer did in the very controlled setting where you don't have cold chain issues and you don't have exceedingly old people with a lot of comorbidities as much as you have in real life. But still, we were able to reproduce this data. And when you look overall at hospitalizations in Israel by age, you can see how we started vaccinated on December 18. And you can see that about 3 weeks later, when we mainly vaccinated those over 60, you can see a dramatic decline, continuous decline in new admissions to hospital at this age group. As we started vaccinated later on, around January 9, I guess, we've started vaccinating the younger age groups, or maybe 19. And then about 3 weeks later, you begin to see the decline in overall hospitalization in the younger age groups as well. So to finalize, what we see is that, first of all, you can do probably a proper retrospective data-driven assessment of vaccine effectiveness that could emulate what happens in a clinical randomized controlled trial. You need to have a lot of data available for you to do this, and you need to be very careful about your methodology and doubt every step of the way. And we are in the process of working on a formal manuscript, making it available, and we hope to do that soon enough. And it will contain a lot more data and many more outcomes and some more data about the methodology. So in this, I would like to conclude and thank you all.